Bismillah ar-Rahman ar-Rahim. Good evening, everyone. We're gonna start today with neuromuscular series. It's actually the second one this time. And today would be updates in Guillain-Barré syndrome. GBS is a strange entity, and sometimes we call it a disease which is good because it's treatable. We have two great speakers today, Dr. Aisha Sharif and Dr. Deep Kayed. The first talk would be held by Dr. Aisha Sharif, and it's going to be about GBS diagnostic criteria. Dr. Aisha Sharif is a prominent neurologist and neuromuscular consultant from Saudi Arabia, and she works in King Abdulaziz Hospital. She is also associate professor of neurology in King's Abdulaziz University, and she has also academic officer in Saudi neuromuscular and electrodiagnostic medicine chapter. She has been very active in the last few years. We've been always together, and she is a very good speaker. And we'll start today with her talk, which is GBS diagnostic criteria updates. Dr. Aisha Sharif, go ahead, please. Able to see now. Good, perfect.
Now? Okay.
Yes.
Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Today my talk will be about GBS diagnosis update. I will start by some historical background. AIDB is an inflammatory disease of peripheral nervous system characterized by lymphocytic and macrophage infiltrate that destruct the myelin sheath. The condition is designated as Landry-Guillain-Barré syndrome, which this is a recognition provided by the description provided by these author. The first case, which was described as a case of ascending predominantly motor weakness with death, was reported by Landry at 1859. The clinical pictures of Guillain-Barré syndrome is considered a diverse disorder. There has a several manifestation which is divided based on several patterns according to the predominant motors, either fibers involvement, pathology, either demyelinating or axonal, or based on the predominant involvement of the motor fibers like the axonal GBS AMAN, or the typical types which involve motor sensory fibers like EIDB or AMSAN, or it can be a pure cranial like polyneuritis cranialis, which one of the GBS variant. The most common pattern in Western region is the EIDB types, which is typically reported to have ascending weakness involving initially the leg and go up, but for sure it's not always the case is ascending weakness involving the leg. It can involve also the upper limb as initial presentation. There was a several diagnostic criteria which was proposed over the last decades to establish the diagnosis of Guillain-Barré syndrome. The initial criteria was the NINIS criteria, the National Institute of Neurological Disorder and Stroke criteria, which was at 1978. It's underwent modification in 1990. And later consensus statement, which was evidence-based guidelines at 2019, they went through also this criteria and they made some modification. The criteria required to have a feature has two parts initially, which is feature required for diagnosis and feature that strongly support the diagnosis. A feature that required the diagnosis is a progressive bilateral weakness of arm and leg, and absent or decreased reflexes in the affected limb. While the feature that strongly support the diagnosis of Guillain-Barré syndrome include progressive phase last from days to 4 weeks, usually less than 2 weeks, relative asymmetry of symptoms and sign, because asymmetry is not a feature of Guillain-Barré syndrome, relative mild sensory symptoms and sign, cranial nerve involvement, especially facial diplegia, is one of the common features of Guillain-Barré syndrome. Autonomic dysfunction, also one of the recognized features that associated with Guillain-Barré. Muscular or radicular back pain of or limb, and this is reflect the root involvement. The CSF finding was typical for GBS, which is the increase the CSF protein and the normal white BC count, and electrodiagnostic feature that support GBS and GBS variant. The modification that made with the new consensus guidelines is the feature that cast doubt the diagnosis of Guillain-Barré syndrome, which is first increase the number of mononuclear or polymorph nuclear cell in CSF more than 50, or marked persistent asymmetry, bladder or bowel dysfunction at onset or persistent during the disease course, severe respiratory dysfunction with limited limb weakness. This should direct you toward other differential diagnoses like a bulbar onset motor neuron disease, but for sure the onset is quite different. Or for example, myasthenia gravis predominantly can present with predominantly respiratory dysfunction. Sensory sign with limited weakness at onset is not a feature of typical GBS, but for sure a rare variant of GBS, which is the pure sensory types, can have predominant sensory symptoms. Fever at onset and nadir less than 24 hours. GBS is not acute, is not a hyperacute disease. GBS is subacute disease. So you cannot expect GBS if the patient is having onset of patient have onset within hours or seconds. You shouldn't expect GBS as a differential. Also, sensory level finding. This will support diagnosis of spinal cord insult. Hyperreflexia or clonus is not a feature of Guillain-Barré, but we need to keep in our mind, as we'll talk later on, a man, which is the pure motor types of GBS, can have hyperreflexia. Extensor plantar responses also is not a feature of Guillain-Barré. Abdominal pain, patient with acute polyneuropathy and abdominal pain should direct you toward other differential like porphyria. If there is a slow progression with limited weakness without respiratory involvement, or continuous progression for more than 4 weeks, should direct you toward the other type of chronic demyelination, which is the CIDP, more than to consider GBS. And altered level of consciousness for sure is not a feature of Guillain-Barré, but as I mentioned, GBS variant has a diverse manifestation. So in case of GBS variant Becker-Staph encephalitis, you can have conscious impairment as exceptional presentation. This is another diagnostic criteria which was proposed as 2011, which is Brighton criteria. It's almost similar to Nenet's criteria. The only difference, they add that monophasic course as one of the feature. Also, they add absence of alternative diagnosis for weakness. And they divide it at a different level of diagnostic of certainty from grade 2 to 4. And this is according to the presence and absence of these features. The annual global incidence of GBS is approximately, it's 1 in 100,000 persons per year. And it's most of the series, there is a modest male predominance in the involvement of male predominance over female in the presentation. 2/3 of Guillain-Barré syndrome, it's usually followed a trigger infection. And most of the GBS cases is related to the incidence is increasing toward the outbreak. Example of this is the outbreak of Zika virus, which was in France at 2013, and also it was in Latin America 2016, which was associated with outbreak of Guillain-Barré syndrome. This is an example of other organisms that can trigger Guillain-Barré syndrome. One of the commonest organisms is Campylobacter jejuni, which was positive around 28% in GBS cases and 67% in GBS axonal types, the pure motor type. Other organisms including Mycoplasma pneumonia, viruses including cytomegalovirus, Epstein-Barr virus, smallpox vaccine, hepatitis B, E, and HIV viruses. For sure, we are in 2020. We cannot pass a presentation without talking about coronavirus and its association with Guillain-Barré syndrome. The initial report for the first month in Italy showed 5 cases was linked to the presentation of coronaviruses. After that, more wider review, which is include 13 countries from 1st of June to 30 June, and they reported around 42 patients linked to be associated GBS with the coronavirus. In this table, summarizing the clinical feature of the reported GBS cases associated with coronaviruses. As you see, the most feature is typical for EIDB case, which is the facial dysplasia, forelimb weakness, and sensory symptom. So the commonest type, 30 cases, was showed EIDB feature, the classic GBS. For the antibodies, it was only one positive in one case, the GQ1B. And for MRI finding, it was positive in 10 cases. 5 of them is cranial nerve involvement, and 5 of them is enhancement of the lumbosacral root. Regarding the respiratory failure in these patients, the non-invasive ventilation was 2, while invasive ventilation was 12. They tried to have a relation between the onset of COVID-19 and GBS. And as you see in this table, it showed that 2 patients, GBS was the presenting feature of corona, while the interval onset in 36 patients between the COVID infection and the GBS was 11 cases, and 11 patients developed Guillain-Barré syndrome after complete recovery from coronaviruses. Here showing the outcome of the reported, the 42 patient GBS, which was associated with coronavirus. The death was only 1 patient died after with the GBS, while the outcome in general was good prognosis. 16 patient definitive improvement, and 7 was has complete recovery. Also, GBS is not triggered only by infection, is well known to be associated with some drug like chemotherapy, example, the immune checkpoint inhibitors, which is used to treat malignancy. And most of the cases has a typical feature of IDB, with difference that it's tend to be have more pilocytosis in the CSF. This is another list of triggers of GBS with unknown mechanism like surgery, epidural anesthesia, thrombolytic agent, and heroin use. And this slide, you see, as you see, the presentation of GBS and GBS variant is variable, with the different pattern of distribution for the motor and sensory finding. As you see in the Aman is a pure motor, parabarotic form, which is involved only the leg. And here is the cervico-pharyngeal-brachial variant, which is presented with difficulty of swallowing, neck flexor weakness, and shoulder weakness. And here, this is interesting pattern that the patient will have only bilateral facial weakness, no weakness elsewhere, but he will present it also with bilateral hand and feet numbness. This is the types that have a pure sensory manifestation, and anti-GQ1B spectrums, which is Miller-Fisher and Becker-Staff, which is associated with ophthalmoparesis and associated with CNS involvement. This is another study. They reported the different GBS variant, which is the classic GBS, as we mentioned, the pharyngeocervical variant. Acute pharyngeal weakness, acute dysphagia in isolation can be a presentation of Guillain-Barré syndrome, and this may create a clinical dilemma in the diagnosis because mimic other differential, and it's not a usual presentation for the typical GBS. Parabarotic form, bilateral facial weakness with no limb weakness and paresthesia of the limb is one of the well-known GBS variant. The other variant is polyneuritis cranialis, which is involve only the cranial nerve, predominantly the bulbar and ocular nerves. These patterns considered to be an interface between GBS and Miller-Fisher variant. The Miller-Fisher syndrome, which is considered also as anti-GQ1B syndrome, it is classified as a classic Miller-Fisher, which is the classic Miller-Fisher, which is the ataxia, areflexia, ophthalmoparesis, or can be presented with more focal weakness, like only acute ophthalmoparesis in isolation, acute ataxic neuropathy, acute ptosis, acute mydriasis, or it can be the extreme, which is the Bickerstaff encephalitis. The frequency of GBS variant is variable from countries to countries. As you see, the EIDB is the commonest type in Europe and America, which is more than 90%, while the frequency of IDB, when you go toward Asian country, the incident prevalence is increasing, 46% Pakistan, 36% in Japan, and 24% in China, 22% in Bangladesh. While if you go to Oman, which is only 4% reported in Europe and North America, when you go toward Asian country, the percentage is the opposite, is increasing, 31 in Pakistan, 38 in Japan, and 56 in Bangladesh, 65 in China. Here, as you see, this is the pathogen, just a slide showing the pathogenesis of Guillain-Barré, how it's triggered by bacterial infections, which is mimic an antigen of ganglioside. This is induced the anti-ganglioside antibody, which is target the node of Ranvier structures of the nerves, which is important as a to help saltatory conduction in the neuron. This table summarizes the antibodies that was frequently reported in relation to Guillain-Barré syndrome. First one in EIDB, there is no common antibody was reported in relation to EIDB, but the antibody was commonly reported with AMAN and AMSAN, which is different antiganglioside, GD1A, GM1, GM1B, in less than 50% of the cases. For Miller-Fisher syndrome, the commonest antibodies is anti-GQ1B, more than 90% in the cases. For the variant, which is acute pharyngocervical brachial variant, also there was a report of anti-ganglioside with GT1A with a known percentage. For other antibodies that was reported to be associated with Guillain-Barré syndrome is the ganglionic acetylcholine receptors antibody, which is not commonly tested. This is a study showed they tried to see how frequent the ganglionic acetylcholine receptors antibody and how can be helpful to establish diagnosis of Guillain-Barré syndrome. And they divided the study into the patient group in two groups, which is the patient with autonomic symptoms and with no autonomic symptoms. They found that the ganglionic acetylcholine receptors more positive in patient with autonomic feature. Again, the slide showing the anti-GQ1B antibody syndromes with variable frequency. The commonest type is the classic Miller-Fisher, followed by the acute ophthalmoparesis, the isolated ophthalmoparesis, Bickerstaff encephalitis, and some groups lie in the middle with overlap symptom from all these patterns. Just one slide about Miller-Fisher, which is a well-known syndrome associated with ophthalmoplegia, ataxia, and areflexia, associated with anti-GQ1B, but also there was a report of other antibody that can be positive with this syndrome. But the case is not always straightforward, it's not always a triad. Sometimes they can be associated with facial weakness. As I mentioned, Bickerstaff encephalitis is the spectrum. It's the extreme of Miller-Fisher syndrome, which is associated with disturbed level of conscious, hyperreflexia, ataxia, and ophthalmoparesis, which is mimic a brain stem insult. Also, the MRI finding sometimes can complicate the issue by finding a high signal intensity in 3% of the cases. Now I will talk about Amman, which is considered the commonest type in Asian country. It's typically ascending, pure motor weakness, but sometimes it can be some sensory impairment. I would like to stress reflexes with Amman. It's typically absent, but sometimes can be normal to hyperreflexia, which can create some confusion in the case. Also, again, the case is not always straightforward. Sometimes Amman associated with other central features, cerebellar ataxia. There was the one report showed that case typically of confirmed Amman by electrodiagnostic feature, by the presence of anti-ganglioside antibody. And the presentation was very atypical. He presented with left side hemiplegia. After follow-up, the patient developed weakness in the other side. So sometimes a typical presentation is exist. CSF analysis to diagnose GBS. It's one of the well-known modalities by finding the cytoalbumin dissociation, but keep in your mind first week, only 50 to 60% will have this abnormality. The yield of CSF increase toward the third week. And typically there is no high white BC count with normal, with high protein. Now we'll come to the electrodiagnostic feature for Guillain-Barré syndrome. For sure, electrodiagnostic feature is very important, not only to confirm the diagnosis, but also to find out the exact classification of GBS and to assess the prognosis. But in fact, this electrodiagnostic study can be normal in the first week. So we shouldn't exclude the diagnosis of Guillain-Barré if you have normal nerve conduction study. So serial electrodiagnostic study is helpful to find out the diagnosis and the classification of GBS subtypes. As I mentioned, first week nerve conduction study can be negative, but this doesn't mean that you need to delay the nerve conduction study because of low yield. Still, there is a several studies showed early electrodiagnostic study of GBS can have abnormality. This is one of the study that they study around 31 patients, and it showed the commonest abnormality observed before during the first week is the H reflex, while followed by the F wave abnormality. SNAP responses also was reported to be abnormal in 61% of the cases in this study. CMAP abnormality in 71%. So this is mean still you have abnormality in the different parameter. So it's better to do the nerve conduction as early as possible. If it's negative, you can repeat it. This is another study for the very early signs, electrodiagnostic sign in Guillain-Barré syndrome, and it showed that still in the first week you can find some abnormalities. They found F wave abnormal in 47%. The reduction of SNAP was in 45%. Also, the CMAP was reduced in 31%. Now we'll come to the electrodiagnostic criteria for Guillain-Barré syndrome. The electrodiagnostic criteria for Guillain-Barré syndrome was changed over decades. The old criteria, which is H.O. et al., which was proposed at 1995, which is based on the conduction velocity, distal latency, conduction block, and F-wave latency. Followed by several criteria. The latest criteria was 2015 Rajbali criteria. It's quite similar, but the difference is in the percentage they accepted. Maybe it's more accept more or can diagnose more severe cases. As you see here, conduction velocity, they accept less than 90%, while Rajbali criteria, they accept only less than 70%. Again, for latency, the old criteria, they accept more than 120% to 110%, while in the new criteria, they required more than 150% beside the conduction block and F-wave latency. For the new criteria, which was proposed as 2017, which is Anthony GBS group criteria, they make some changes over the old criteria, and they introduce the duration of CMAP as one of the criteria. Also, they introduce the abnormality of ulnar nerve with sparing sural snap as a feature. All the old criteria was there, the sensory response was not part of the feature. So this is the new changes which was introduced as 2017. They include sparing sural response as one of the criteria. Also, the AMAN, the axonal motor neuropathy, there was several criteria in the past and recent criteria. The only difference between the past criteria and new, that with new criteria, they accept in the requirement to have a demyelinating feature in association with AMAN. As you see here for the Anthony GBS group criteria 2017, they accept to have demyelinating features in one nerves if the distal CMAP less than 20%. Also, they accept to have another demyelinating feature, which is called a reversible conduction failure. I will talk about it later in the next slide. They accept to have what we call it a reversible conduction failure in case of AMAN, which is a well-known axonal motor neuropathy. The reversible conduction failure, it's a features that you have a transient conduction block feature and slow conduction velocity in associated with patient with a pure motor weakness. This study showed that they evaluated a 25 patient of AMAN, and they found 48% of the patients that have pure axonal. But in fact, there was a 20% of them, they have a transient conduction block and slow motor nerve terminal. 12% they have F-wave abnormality. So still in the AMAN, you can have, and you need to accept presence of a demyelinating feature, or what we call it a reversible conduction failure, which is reflect that the antibodies is attacking the ganglioside in node of Ramsey. This is another just case that I want to stress on, which is recently described, the acute motor conduction neuropathy, conduction block neuropathy. These are report of several cases with typical ascending motor weakness, with a typical CSF finding and positive anti-GM1 antibody, but the nerve conduction study showed pure demyelinating conduction block failure, which is not a typical for AMAN. So they call it acute motor conduction block neuropathy. So they think that the acute motor conduction block neuropathy, AMAN with reversible conduction failure, and typical axonal classic AMAN is a pathophysiological continuum, and the acute motor conduction neuropathy is just a mild form of AMAN. Sensory nerve conduction study need to interpret it carefully in patients with GBS, because some patients, they have diabetes, so they have already absent sensory response. We cannot put a lot of money in this finding. The most important thing is the sural sparing, that now one of the criteria that you can rely on in the diagnosis of Guillain-Barré. I will just go through other diagnostic feature for GBS, which is MRI, which is also one of the modalities that will known to evaluate the root and nerve. It's non-specific but sensitive to show a root enhancement. The last thing I would like to talk about is the role of ultrasound in diagnosis of GBS. Ultrasound is now one of the new potential diagnostic tool because it's an easy, non-expensive to evaluate a different neuromuscular disorder. This is one of the studies that showed that using ultrasound of the cervical root was associated of a positive was associated with positive finding that early GBS, they have a large cervical nerve root diagnosed by ultrasound. This is another study which is a serial peripheral nerve ultrasound in Guillain-Barré. This is also interesting study that showed that evaluation cross-sectional area of median and under nerve and ulnar nerve and sural in the first 3 weeks showed enlargement, and with subsequent follow-up, it showed improvement over the course of the disease, but not correlating with the motor or electrodiagnostic feature. So this means we can use also ultrasound to assess the follow-up and outcome of the patient. This is a recent study done in Egypt. Also, they evaluate the cross-sectional area of the nerve. They found most of the patients in early phase of GBS, they have enlargement of the nerve in comparison to the control. Last thing I will talk about also, this is also one of the interesting studies which in which they not evaluate only the, they did not use the ultrasound only for diagnosis of GBS, but they use it to diagnose subtypes of GBS. They found that patient with SAN and AMAN, they tend to have a more increased cross-sectional area in the distal part of the nerve. While in case of classic EIDB, they tend to have more enlargement in the proximal part of the nerve and cervical root. So this is mean ultrasound also can play a role in the future in classification of Guillain-Barré subtypes. This is the end of my talk. So just to say, diagnosis of GBS is based on clinical history exam, supported by ancillary tests like CSF and electrodiagnostic study. And we shouldn't delay electrodiagnostic study because still in the first week you can't find something to help you in the diagnosis. GBS variants and subtypes has variable and atypical presentation, which is require a high degree of suspicion to pick up the diagnosis. So I can stop here. Thanks for your listening.
Thank you very much, Dr. Aisha. Very excellent talk. We reached almost to 700 and one left became 699. So I'm looking for that person, Dr. Deep Kaid. Dr. Kaid is the next speaker. Dr. Deep is a good friend of mine. We have clinics together in the afternoon. He is a consultant neurologist. He graduated from United States and did his neurology residency over there, and he had fellowship in neurophysiology. He has main interest in headache and neurophysiology. I also trust him and referring him many cases because he's good, an excellent physician. His talk today would be in updates of treatment for Guillain-Barré syndrome. Dr. Deep, go ahead.
Good evening, everybody, and thank you, Dr. Abu Bakr. Are you able to see my screen?
Yes, we can.
Okay. Thank you very much for inviting me to give this presentation. As you said, I am a clinical neurophysiologist, so I do enjoy that part of neurology as well. I was tasked with the topic of Guillain-Barré syndrome therapy update. I have no conflicts of interest. So, Dr. Aisha told us how we diagnose Guillain-Barré syndrome. Now we are on call and a patient presents to the emergency department and we examine the patient and we see that they, on clinical grounds, fulfill the criteria for Guillain-Barré syndrome. Now what do we do? I think a very, very good guideline is the same one that Dr. Aisha showed in her first few slides, It's a certain review of guidelines with recommendations published in Neurology in November, Nature Neurology Reviews in November 2019. And it talks about 10 different steps, including diagnosis and treatment, that you need to pay attention to treat the patient adequately. So I think once you think that the patient has Guillain-Barré syndrome, the most important thing you can do is monitor the patient, and especially monitor their respiratory function. We know that the most common reason for death, or the reason for death in patients with Guillain-Barré syndrome, is either respiratory failure or autonomic insufficiency. So how do we assess their respiratory function? Well, by simple examination, use of accessory respiratory muscles. You can also ask the patient to count, and I do this routinely for all my patients. I ask them to take a deep breath in and count during exhalation. 1, 2, 3, 4. And in this guideline, they say that if you are not able to reach 19 in one breath, that's a sign for a requirement for mechanical ventilation, or that you need to be observed much more closely. What I did in my residency training, and I try to do that here, but some hospitals do not allow me that capability, is to do bedside forced vital capacity. And some people do maximum inspiratory and expiratory pressures. I don't use this 20, 30, 40 rule, but it is out there for you to use if you'd like to. I do look at vital capacity, as I said, and usually we're looking at, depending who you look at, 15 to 20 ml per kilograms. So if you've got somebody who is 75 kilos, 20 ml per kilogram is what? About 1.5 liters. So if somebody's vital capacity is only about 1.5 liters, this is somebody that you need to watch very closely for the possibility of respiratory failure. Of course, you can also use the 30 centimeters of water for maximum inspiratory pressure and the 40 centimeters of water for maximum expiratory pressure, but personally, I only use the vital capacity. So it is not only respiratory function that we look at muscle strength, and we shouldn't forget neck flexion and extension. And we do that part of our neurological examination. We check their strength in different muscles on a daily basis to see whether there is improvement or deterioration. We also monitor swallowing and coughing, bulbar functions that are quite vital, and if compromised, also warn us about impending respiratory failure. And we also monitor autonomic dysfunction, and therefore if the patient is on the ward, it is quite useful for them to be monitored with telemetry, for example, to look for any arrhythmias, with frequent heart rate and blood pressure monitoring, as well as asking about bowel and bladder function control. Up to 2/3 of deaths of patients with GBS occur during the recovery phase. And I must say, this has been a surprise to me. You know, I must see about, on average, 1, maximum 2 Guillain-Barré syndrome patients per year, more like 1, I think. So over the last 10 years, I think I've come across 10 of them. The last one was only a couple of months ago, and it was post-COVID, actually. The guy got COVID, he was getting better, and as he got better, he got some bulbar symptoms and became weak and couldn't swallow and breathe, and necessitated the intubation. And electrophysiologic studies showed an axonal variant of Guillain-Barré syndrome, the AMAN variant, and he received treatment, and he is getting better, but slowly. He is older and he has many comorbidities, which are poor prognostic factors. So it is not only at the time of admission that we need to be careful, but is as the patient is getting better, because of the potential for arrhythmias, blood pressure fluctuations, and also mucus plugs. Somebody's getting better, for one reason or another, they do not breathe adequately, they develop a mucus plug, and next thing you know, they're dead in bed on the ward where nobody's watching them because everyone thinks they're getting better. So the question is, when do we admit this patient to ICU? The patient came through the emergency room. Let's say we made the decision to admit them to the ward. How do we decide if they go to ICU or not? Well, we look at respiratory distress with imminent respiratory insufficiency, and I'll talk about respiratory insufficiency in the same slide a little later on. We look for autonomic variations, arrhythmias, blood pressure variations. We look at swallowing function. We look at rapid progression of weakness. Somebody who comes in and you examine him and he has decent strength, and then the next day he is significantly weaker, that's an alarm. That should ring bells that we should monitor this patient much more slowly. Imminent respiratory insufficiency, we touched on that in the previous slide, but it's so important, I think we should go about it again. Breathlessness at rest or during talking. In this guideline, inability to count to 15. So in the last slide, it said 19, here it says 15. I think it's important that you get yourself into the habit of asking the patient to count and doing it daily and seeing if they are deteriorating or not. Use of accessory muscles, again, vital capacity is what we mentioned, 15 to 20 ml. Once you hit the 1 liter mark, you're really very close to being intubated. And some people argue you should be perhaps prophylactically intubated. If you wait for abnormalities in arterial blood gas or pulse oximetry, you've missed the boat. People can have close to normal blood gas and pulse ox readings, very close to impending respiratory failure. Up to 22% of patients with Guillain-Barré syndrome will require mechanical ventilation within the first week of admission. So it's really that's the critical period of time to watch patients, because about 25% of all patients will require mechanical ventilation, all patients with GBS. There is a tool out there, a prognostic tool. I do not personally use it, but I thought I'd share it with you in case you are interested. It's from the Netherlands, from the Erasmus group. It's a GBS respiratory insufficiency score prognosis tool. And it can give you a probability of 1 to 90% that the patient may require ventilation within 1 week of assessment based on various features that you will enter from your exam of the patient. The risk factors for prolonged mechanical ventilation include inability to lift the arms from the bed at 1 week after intubation, or an axonal subtype or unexcitable nerves on electrophysiological studies. So now the patient is admitted, whether it's ICU or whether it's to the ward, we need to treat them. We've established that they have Guillain-Barré syndrome. We don't need a lumbar puncture, although I always do a lumbar puncture. We don't need electrophysiologic studies, although I always do electrophysiologic studies. As you saw, the criteria for diagnosis are an ascending symmetric weakness mainly, and areflexia or hyporeflexia. So when to start treatment? The standard teaching, and this I can remember from nearly 30 years ago during my training, is that if the patient can still walk, you don't need to give them treatment. So what people use is, if the patient's unable to walk independently for 10 meters, then you need to give treatment. I personally do not subscribe to this, and I don't understand the rationale for this. Well, the studies give you a rationale, but I'm not so convinced. So the problem with the studies is that if the patient is walking, it's difficult to prove that the treatment is efficacious in them. I don't see any harm from giving them the treatment anyway. The only harm is that the cost of the medicine, and perhaps if you want to be purist, there's not enough evidence out there to tell you that treatment in people who are able to walk independently makes a difference in the long run. Perhaps it hastens recovery, I'm not sure. So patients who are not able to walk independently for 10 meters, patients with rapidly progressive weakness, patients with autonomic dysfunction or respiratory insufficiency ought to get treatment. And if you decide to give IVIG, and the two mainstays of treatment are intravenous immunoglobulins and plasma exchange, if you decide to give these, IVIG has been shown to be beneficial if you give it within the first 2 weeks. Plasma exchange, you can give it within the first 4 weeks and still hope for a response. Beyond these time periods, there is really no proof that these treatments do anything. So the standard treatment for intravenous immunoglobulins is what we all know, 0.4 grams per kilogram body weight per day for 5 days. That's the standard protocol. Plasma exchange, it's about 200 to 250 ml plasma per kilogram body weight over 5 sessions. Depending on the kind of hospital you're in, you either give this to your hematologist to do, or to your intensivist, or to your nephrologist. They are used to these plasma exchange sessions, and they know what to do, basically. So I'm not going to review the evidence here. Suffice it to say that IVIG and plasma exchange are equally effective and pretty much compatible with risks of serious adverse events, let's say. There are some subtle differences, but they're comparable treatments. Why do we give IVIG most of the time rather than plasma exchange? Because it's easier to do. It's 5 days. It is an infusion. It's not a 10-day course because the plasma exchange courses are usually every other day, 5 sessions. That takes about 10 days. You need to have a central line. You need to replace fluids. It's a bit more complicated. So IVIG is just much easier. No other procedures or drugs have been proven to be effective in the treatment of Guillain-Barré syndrome. But we need to know about the adverse effects. You know, we get signed consents from our patients, and the signed consent I get from my patients for IVIG usually is very limited. It says that IVIG will make you better. The alternative is plasma exchange, and the potential side effects that I usually mention specifically on the consent form are infusion reactions, thromboembolic events, and risk of kidney damage or kidney failure. But if we look at more details at the IVIG adverse effects, majority are transient and mild: flushing, headache, malaise, fever, chills, fatigue, and lethargy. Rarely you can get some serious side effects, including renal impairment, thrombosis, arrhythmias, aseptic meningitis, hemolytic anemia, and transfusion-related acute lung injury. I have had no patients in 30 plus years with aseptic meningitis, renal impairment, hemolytic anemia, or transfusion-related acute lung injury. I've had one patient, I think, with a vascular event that was transient and reversible. I've had plenty of patients with transient and mild events that are infusion-related. So we can think about IVIG having immediate adverse effects, and we can classify those as mild, moderate, or severe. Mild ones just require us to slow the infusion, use some antihistamines, some non-steroidals. I know some people give a small dose of steroids. We shouldn't use high-dose steroids in Guillain-Barré syndrome, but with the IVIG, some people use a small dose of steroids to reduce the chance of infusion reactions. If it's a more moderate reaction, we can stop the infusion for a while, watch the patient. And if it's a severe reaction, we have to stop the infusion and not give it again, and perhaps administer some emergency care if there is anaphylaxis or bronchospasm. The symptoms mostly are flu-like symptoms, but we can get other things, dermatological adverse effects. I have not come across this. Apparently, this happens in up to 6%. They occur within 2 weeks of IVIG, and it's usually related to repeated administration of high-dose immunoglobulin infusion, high dose being the 2 grams per kilogram over a total of 5 days. Arrhythmias and hypotension, again, these most frequently occur in elderly patients with underlying cardiovascular risk factors, especially heart disease. But they can happen in anybody, of course. And therefore, the recommendation is, if you have an elderly patient, it's best to have them monitored during their intravenous immunoglobulin infusions if they have cardiovascular risk factors. The transfusion-related acute lung injury, you can just think about it as the same as the, it's life-threatening. It's the same as the reaction you can get to a bad blood transfusion, and it can be very, very serious with high mortality, and usually happens within 6 hours of transfusion, where you get respiratory distress and non-cardiac pulmonary edema. Basically, you're allergic to something within the IVIG. Remember, IVIG is taken from blood, plasma products, different proteins. So you could potentially be allergic to something in there that causes such a severe reaction. There are delayed adverse effects, and the one we fear most is thrombotic events. Up to about a year ago, I used to only quote roughly a 1% chance, and I did some reading about it a year or two ago. And I was surprised to find out that it's up to 17%, 1 to 17%, depending on what study you look at, risk of stroke, MI, PE, DVT, or any kind of thrombotic event. Now, the risk is most likely to happen, if it's going to happen, after the first infusion of a large dose, if there's oral contraceptive use with older age, with prior or current thrombosis or pre-existing atherosclerotic disease, if there is elevated serum viscosity for whatever reason, and if there is a hereditary hypercoagulable state or immune thrombocytopenic purpura. I routinely administer Clexane 40 milligrams sub-Q once daily for every day that the patient gets IVIG. And actually, I don't know where I got that from. I do it empirically. I figure it will not harm the patient, and it may provide some benefit. And I have had, as I said, in the last 10 plus years, only one case of possible transient thrombotic event. There is in this interesting study in renal transplant patients receiving IVIG for antibody-mediated infections, where they used prophylactic antiplatelet and anticoagulation therapy, and they showed in this one study that there was a significant reduction in the number of thromboembolic events. So this is one strategy that you may consider in your patients requiring IVIG. So in this one study from London, up to 11.3% of patients, this is from Queen Square, with inflammatory neuropathy. So this is very pertinent to Guillain-Barré syndrome, whereas the other one was in patients with renal transplant and so forth. This is an inflammatory neuropathy. Up to 11% of patients over a 2-year period developed a thromboembolic event. I find that very high because that hasn't been my experience, and I'll be interested in hearing from everybody else here what their experience has been. Risk factors, as we said, are coronary artery disease, poor mobility, cardiovascular risk factors, older age. A dose greater than 35 grams per day was associated with an increased risk, and not necessarily the total dose. So it's not if we're talking about 2 grams per kilogram total dose, but it's how much of a high dose. Do you give it over 2 days or do you give it over 5 days? Other delayed adverse events, headache. We've seen patients with headache all the time. If the headache persists, then you have to worry about cerebral venous thrombosis or aseptic meningitis. There's more of a chance of a headache in patients with a pre-existing history of migraine. You can get aseptic meningitis. Again, I have not come across that. The risk factors are migraine and a high cumulative dose. Posterior reversible encephalopathy syndrome, seizures can happen, but if you get a seizure, look for a cause. Is there aseptic meningitis? Is there PRES syndrome? Is there cerebral venous thrombosis? And abducens nerve palsy has been reported as well. And in that one case that it was reported in, it was with aseptic meningitis. A couple of other cases were reported. Nobody really knows the mechanism of it. Maybe directly related to the Guillain-Barré syndrome, maybe not. Sorry, to the IVIG, maybe not. Other adverse events that can happen include renal impairment, hemolysis, electrolyte disturbance. Infection risk, this is no longer an issue, but in the past when the blood products weren't adequately treated, hepatitis C and prion disease occurred. Beware of one thing, you can pass on passive immunity with hepatitis B serology. So someone receiving IVIG may show that he is having antibodies to hepatitis B, but not be a true immunity, because this is just passive, taken from the IVIG and will fade away within a few weeks. What are the adverse effects of plasma exchange? There's a complication rate up to 36%, a little bit more than what we talked about with IVIG, but most of these are minor, really no deaths with it. The most common complications are fever, urticaria, and hypocalcemic symptoms, because when you do the plasma exchange, a lot of calcium goes out, you have to make sure to replace it. There are more complications if you use fresh frozen plasma as opposed to albumin saline infusions with the plasma exchange. And I checked this morning with one of the physicians that does this, and he cannot remember the last time he used fresh frozen plasma. It's only if you run into problems, complications, bleeding, that you will use fresh frozen plasma. So the complications are way less with albumin saline replacement than with fresh frozen plasma. Corticosteroids, in a nutshell, no, no, and no. Don't give it. It doesn't help. There's some reports it might actually have a negative outcome. And there's insufficient evidence about combining high-dose pulse steroids along with IVIG. How about using these treatments in Guillain-Barré syndrome variants, so something else than AIDP? Well, if we heard about the Miller-Fisher syndrome, and interestingly, the guideline says these people, most of them will get better within 6 months. Don't treat them. I find that a bit difficult. Somebody coming to me quite ataxic, if I can give him a treatment that may hasten his recovery, why wouldn't I do that? But I have to tell you what the recommendations say is that most people recover completely without treatment within 6 months, so you don't really have to give it. Now, if the patient has Miller-Fisher syndrome plus some bulbar symptoms, some autonomic issues, some respiratory issues, then it's probably best to give it. We also heard about Bickerstaff brainstem encephalitis. Again, most people, as bad as they get, they can be even comatose. That's how altered their mental status can be. I've never had a case with Bickerstaff, but supposedly most people, as severe as they are, will eventually recover. But I think you're going to be hard-pressed to see somebody comatose there, and you think they have Bickerstaff and say, okay, let me wait and see what happens. I think treatment is probably prudent in these patients. There's no evidence regarding treatment for other variants for Guillain-Barré syndrome specifically. How about Guillain-Barré syndrome in treatment in pregnancy? Neither IVIG nor plasma exchange are contraindicated. Plasma exchange requires additional considerations in pregnancy. IVIG is usually preferred. In children, we don't have any data, and therefore there is no need to deviate from standard adult practice, which is IVIG or plasma exchange. In children, you can imagine how difficult plasma exchange might be, and therefore IVIG is usually the first thing we go to. Some pediatric centers give the IVIG over 2 days rather than over 5 days. But treatment-related fluctuations, and I'll talk about that in a couple of minutes, seem to be much more if you give it over 2 days rather than over 5 days. So, do people respond? About 40% of patients treated with either plasma exchange or IVIG do not improve in the first 4 weeks of following treatment. Remember, with Guillain-Barré syndrome, you do not progress beyond 4 weeks, and most people reach their nadir at 2 weeks. So just because you've given their treatment and the patient hasn't responded, it doesn't mean that the treatment didn't work. Perhaps if you didn't give the treatment, they would have progressed further. So people usually, when they don't see an adequate response, immediately think, what can we do next? Should we give another course? Should we repeat IVIG, repeat plasma exchange, give the other modality? Currently, there is no proof that doing anything more is of any benefit. There are upcoming trials, 3 trials we hope to get the results of. One trial will address a second IVIG course after the first course. If patients have a poor prognosis, like an axonal variant, or don't seem to be responding, we hope to get that result to see if there's any point of giving a second IVIG course. Euclizumab, which was recently approved for myasthenia, is also being studied to see if it has any benefit in Guillain-Barré syndrome. And there is this study in rabbits about IgG degrading enzymes, looking at complements and seeing if they can help with Guillain-Barré syndrome. So there are new therapies or new approaches to therapy that are being investigated. I mentioned treatment-related fluctuations, and those occur in up to 10% of patients, and they are defined as the following. Following an initial treatment-induced clinical improvement or stabilization, there appears to be disease progression that occurs within 2 months. If you have that situation, then this is called a treatment-related fluctuation, and this should be distinguished from clinical progression without any initial response to treatment. So treatment-related fluctuation, the patient gets better and then appears to get worse. The general view is that these treatment-related fluctuations indicate that whatever treatment we gave, its effect wore off, but the inflammatory course of the disease seems to be ongoing. Although we said patients usually reach a nadir or do not progress beyond 4 weeks. So patients with Guillain-Barré syndrome who have treatment-related fluctuations might benefit from further treatment, and this happens commonly. We do that. We see a person who gets better, they get worse, and then we give them a second course of IVIG, or we do something else. Is there proof for this? Not really, but it's difficult to do nothing when we see the patient deteriorating again. The problem comes when we think about, is it Guillain-Barré syndrome? If it's the first time and it's acute or subacute, as we were told, then that's reasonable. But sometimes CIDP can start acutely. So you can have an acute presentation of CIDP, and usually if we have 3 or more treatment-related fluctuations over 8 weeks, then from disease onset, then we can think that perhaps this is CIDP that started off like a Guillain-Barré syndrome, but it's not truly Guillain-Barré syndrome. The recurrent risk of Guillain-Barré syndrome is only about 2 to 5%. Other things we should not neglect is rehabilitation. Don't do it excessively to cause fatigue. We want to avoid fatigue. These patients have fatigue anyway. We need to treat pain. Pain is a prominent component. I remember one of my patients with severe excruciating pain, and the pain could be muscle pain in the lower back and the limbs. It could be painful paresthesias, arthralgias, radicular pain. Whatever pain it is, you need to treatment, whether it's with non-steroidals or with adjuvant treatments like anti-seizure medications and antidepressant type medications for neuropathic pain. What is the prognosis? So we've treated the patient, or we see the patient and they ask us, what's going to happen to me, doctor? What can we tell them? Well, we can say that about 80% of patients with Guillain-Barré syndrome are able to ambulate independently by 6 months after disease onset. About a quarter of the patients will require artificial ventilation. Mortality is about 3 to 10%. This hasn't been my experience. I don't know why. I don't know if this is all data, but this hasn't been my experience. The risk factors usually is advanced age and severe disease at onset. Long-term residual complaints can remain, including pain and weakness and fatigue, and incomplete recovery. But the good news is that recovery will continue to happen even 5 years beyond disease onset. Do not forget the impact of psychological factors. Most patients with Guillain-Barré syndrome are healthy and well, and then over a few days to a week or two, they are disabled. And they're wondering what the hell happened. And this can be very anxiety provoking, and this can cause depression. We need to recognize if these things are there. We need to give support. We need to treat if necessary. We need to inform the patient about the relatively good prognosis of Guillain-Barré syndrome, that most people will do well, will survive, and will fully, if not nearly fully, recover. That will provide them with some sense of reassurance. I'd like to end with the last 2 or 3 slides talking about vaccination. Yeah, many vaccines carry a warning about Guillain-Barré syndrome. If you look at the package inserts of all these vaccines, there is a warning about it. However, it is not a strict contraindication. No definite causal relationship has been established except in 2 situations, once with the rabies vaccine when they prepared it from infected brain tissue, and another one during the 1976 swine flu vaccine. And the risk was just 1 extra case per 100,000 vaccinations. There are some studies there with the influenza season of 92 to 93 and 93 to 94 showing a relative risk adjusted increased at 1.7 per million. However, there are other studies out there where really it calls into question the link between Guillain-Barré syndrome and vaccines. A review, and this is important to know, a review of all post-vaccination cases from 1990 to 2005 did not reveal an increase in mortality with post-vaccination cases of Guillain-Barré syndrome compared with cases resulting from other causes. So just because you get it post-vaccination doesn't mean it's going to be worse. I hope that this gave you an idea about an update in therapy with Guillain-Barré syndrome, and we're all happy to take some questions. Thank you.
Excellent talk, Dr. Deep, as usual. I hereby invite Dr. Aisha and Dr. Deep to present. We have 30 questions. We're going to try to solve all of them or answer all of them.
Dr. Abu Bakr, you being as well the neuromuscular subspecialist, please feel free to answer as many as you like.
Of course. I'm trying to type most of the answers. Good evening. Are there any predisposing factor that makes one more prone to develop GBS? Dr. Aisha can answer this, or you can answer.
We don't know what predisposes one patient to get GBS compared to another. We know that very frequently preceding GBS, there is an infectious etiology, as was mentioned earlier, Clostridium jejuni or perhaps Mycoplasma, but we don't know why one patient gets it and the other doesn't. I recently had a patient an Emirati patient who was in London eating sushi in a restaurant with 4 or 5 friends. They all had the same sushi. They all got the food poisoning. They all came back to the UAE. They all got better except this one person. After getting better, he got Guillain-Barré syndrome, and it was quite significant Guillain-Barré syndrome. Why did he get it while his other 4 friends didn't? Must be something genetic that we don't understand.
Yeah, sorry, it was mute. Yes, agree with you. It's nothing. We don't know why some patient is affected and other patient not affected. What other question?
The other question is, can GBS be present also with other diseases? What
does he mean? Mean other?
So is there any association?
Can be associated with other disease. It can be associated as with other disease like paraneoplastic, post-infectious. So the part of the manifestation can be manifestation of the predisposing factors. But GBS itself, it's a pure neurological peripheral nervous system and its complication, either motor, sensory, or autonomic.
This question, I think Dr. Deep has answered, and you have answered as well. How would you differentiate CIDP from GBS?
You want me to answer? Okay.
Okay.
Yes, please go ahead, Dr. Aisha.
Okay, so the main difference between Guillain-Barré and is the clinical diagnosis. It's progression more than 2 months. This is in favor of CIDP. They can mimic each other in electrodiagnostic criteria and CSF study. But the main thing is clinical presentation. If there is a progression more than 2 months, this is in favor of CIDP. Also, if the patient has progressive weakness, sparing the cranial and respiratory function, this is in favor of CIDP rather than to be Guillain-Barré syndrome.
IVIG and plasmapheresis in case of refractory GBS. What's your comments?
So
Dr. Kayet?
Yeah, so there's nothing out there, you know, nobody knows what to do. We always have the dilemma. We give IVIG first, the patient doesn't get better. Do we give a second course, although we don't have data? Do we give a course of plasma exchange and wash out all the expensive IVIG that we just gave? We just don't know. I think we need to wait for the results of those 3 studies to tell us if anything makes a difference. Sometimes it's tough to do nothing when somebody doesn't respond, but what can you do?
One of them asked a question, what's the chance of recurrence of GBS?
Yeah, I think one of the slides showed that about 3 to 5%.
Yeah, I agree. And can GBS or can vaccination cause GBS?
Yeah, again, the last 3 slides, I addressed that. There is controversy out there. It is in the warning for the vaccinations. In those polio and the swine flu vaccine of 1976, yes, it's documented. With the influenza virus vaccine, it's controversial. So if you talk to anti-vaccine people, sure it does. Does it? Nobody really knows. I think nobody knows the exact answer. There's a slight increase. Is it that significant? The benefits of vaccination, I think, outweigh the risks.
One has interesting question. If IVIG and Plex haven't improved the symptoms of GBS, what's the next?
So the next is to revisit the diagnosis, see if you have the right diagnosis. But we know some people don't improve, especially the ones with the severe axonal variants. So what's next is physiotherapy and prayer for the patient. I don't know if Dr. Aisha or Dr. Abu Bakr have other.
Yes, I agree. Yes, I agree. There is no evidence of the prognosis is variable from patient to patient.
I fully agree, but as Dr. Kayet said, you have to revisit the diagnosis. Maybe it turns out to be CIDP rather than GBS in some cases, especially if they are not improving. Then if you suspect CIDP and they are not improving, then you may need to consider other stronger medications such as rituximab or cyclophosphamide. There's plenty of questions. We'll try to answer most of them. Which type of IVIG you select?
Whichever one the hospital has.
Mm-hmm.
You know, the only time, you know, they come in 5% and 10%, and they come with different companies. Of course, if you give the 5%, it's double the time. So sometimes people, you know, I have people who have full-time jobs, and you know, I just had a patient today who got 80 grams IV yesterday and 80 grams IV today. So and he's been getting this for the last few years, every 4 to 8 weeks. I give him the full 2 grams per kilogram over 2 days. So of course the 5% will not work. I give him the 10%, it's a day case. He goes home after the first day, he comes in the next day. I had one patient who had elevated creatinine on the 10%, so I consulted nephrology and his creatinine normalized, and then nephrology suggested that we use the 5% preparation. There is also some older IVIG which contains IgA, and there is the issue of anaphylaxis with IgA and things along these lines. But I think most of the newer formulations or companies are this is not a risk.
One of them thinks that physiotherapy is probably superior to IVIG and plasmapheresis. What do you think about it?
What's the evidence?
Yeah,
No
I
evidence
don't
for
know
this.
of any trial that looked at that specifically. If there is a trial that looked at that specifically, I'd be happy to know it. But what I do know is that trials have looked at IVIG, have looked at plasma exchange, and showed that there is a benefit from the use of these medications.
That's one of the questions interesting here. In severe diabetes who present with GBS, how would you differentiate it by nerve conduction study?
Okay, first of all, if yes, diabetes can make confusion in the electrodiagnostic finding, but GBS, the most important thing, GBS is a clinical diagnosis, and you need to suspect the diagnosis clinically by typical ascending weakness, predominantly motor features, facial dysplasia, and in association with other electrodiagnostic modalities like CSF, high protein, and normal cell. For the electrodiagnostic part, if patient has already his nerve, most of nerve is affected or absent due to diabetes, long-standing diabetes, you can go further proximal to check. Sometimes I go even to do blink reflex to look for demyelinating feature. Also, EMG can be helpful in this case, but not early. Maybe after 2 weeks, you can, if you have significant denervation, FIBS and positive sharp wave, will be in favor of subacute peripheral neuropathy, which is not a usual finding in case of long-standing chronic peripheral diabetic neuropathy.
I fully agree with you, Dr. Aisha. And one features they may need to add doing MRI of lumbosacral spine with contrast. So if there is a contrast enhancement, it may suggest GBS. In Miller-Fisher syndrome, the treatment for facial palsy is similar to Bell's palsy or different?
Facial palsy.
The only thing I can say, of course, with Bell's palsy, we're using steroids. With Guillain-Barré syndrome and its variants, we should not be using steroids. So if we're going to treat, and remember, I told you that some guidelines say Miller-Fisher syndrome has such an excellent prognosis, you don't need to treat, but except in certain situations. So if we're going to treat, it wouldn't be steroids. It would be IVIG or plasma exchange.
Okay. Another question here, maybe it's good to answer because probably most of the attendants are GP here. What's the difference between GBS and multiple sclerosis?
GBS is a demyelination of the peripheral nervous system, so affect the root and nerve only, while multiple sclerosis is demyelination of central nervous system, affect any part of the central nervous system, brain, cerebellum, brain stem, spinal cord, but spare the MS doesn't affect the peripheral part, only central part.
There is a statement here by a doctor. Why GBS is more common in southern region of Kingdom of Saudi Arabia? Almost 15 patients per year in Abha. What do you think the triggers are? Maybe
I'm not
Dr.
sure.
Aisha
Maybe
can...
because the weather is very cold, they got flu and infection that can trigger. But I'm not aware if it's in south is more than other region of country of the Saudi Arabia country.
How many people live in Abha? He's saying 15 cases per year. So how many people live in Abha? You need to know the rate, yeah?
Maybe million? I'm not sure.
1 million maybe, so.
Okay.
It's 1 per 100,000, the incidence, right? That we saw 1 per 100,000.
Yeah.
So if he has a million, then you expect 10 per year.
Well, that's expected. So that's not more common.
Sometimes in the seasons, we can see 10 in the seasons over 2 months or 3 months sometimes in Jeddah.
Okay, I think we answered most of the question. Let's see here. Is there any other things? Can GBS be associated with stroke?
I'm not aware about any GBS as complication of stroke, But GBS sometimes it can have rare presentation like papilledema because increase the viscosity due to the high protein level. But as a stroke, I'm not aware about scenario, but it's a well-known complication of IVIG, the treatment.
So as a complication, as you mentioned, thrombosis may be maybe a complication of GBS because these people most of the time are immobilized. Eating uncooked liver of sheep can cause GBS? Not likely, no. The answer. You agree, guys?
I have no idea. I hope not, because I eat a lot of liver.
So last question here. Eating uncooked liver of sheep can cause GBS?
No evidence about this. I did not come across about this.
We got the answer here. Abha's population is 210,000. That's probably too little.
Strange.
Is it really? I thought it's 1
yes,
million.
I think it's little for... There is one question also here. He said, how common is acute ataxic neuropathy as GBS variant? No, not this. Yeah, he said how to differentiate ataxic neuropathy from sensory ataxic neuropathy. In this, the acute ataxic neuropathy that I mentioned, there is two types. One, ataxic neuropathy as variant of Miller-Fisher, and they think this is not the process, not only a peripheral insult. They think antibody is also attacking the cerebellum. So we'll find the patient, he is ataxic in out of proportion of the sensory manifestation. While the sensory neuropathy of GBS, which is a pure sensory type, the patient will have predominantly sensory feature, numbness of both hand and feet. This is the difference.
Any other questions we missed? You can see the questions, right?
Yeah. I think some question before the presentation, the second. So
some of the questions
you
you guys
answer
answered
already. There is a question how you can differentiate GBS from myasthenia gravis. The myasthenia gravis can mimic GBS in the crisis phase, but usually the patient has previous history of fluctuating weakness. They have bilateral ptosis, double vision, prior patient going to a significant crisis. By the electrophysiology and the myasthenia will not have the cytoalbumin dissociation in the CSF study. The electrodiagnostic feature in GBS, there will be abnormal nerve conduction, while myasthenia gravis, there is normal nerve conduction study. You need to do further tests, which the repetitive nerve stimulation. So it can be differentiated by electrodiagnostic and clinical feature.
You know, I have a question for Dr. Abu Bakr and for Dr. Aisha. With all my Guillain-Barré syndrome patients, I do check a ganglioside panel of antibodies. I do check for Campylobacter jejuni. I guess out of interest, just to see what it shows, but is there any practical reason to check all these? I mean, in the Miller-Fisher, if you get the GQ1B, fine, you've got some confirmation. But is there any, if you're trying to save the patient some money, is there any point of doing these tests?
I usually don't do them unless if I suspect autoimmune process. If I suspect the patient may convert to CIDP as atypical features of GBS, then I do them. Otherwise, I don't. I don't know what Dr. Aisha
all in
thinks.
the atypical cases, we do it.
Yeah, I do it out of interest.
There is one question, GBS can be presented as coda equina-like syndrome. Yes, as I mentioned, one of the subtypes or variant of GBS is the parabarotic form, which is involve only the lower limb. But the difference that coda equina, they tend to have more bowel bladder dysfunction, while GBS, the bowel bladder is less affected.
Yeah, I think we have to be very careful if bowel and bladder are early presentations. Then we have to think other than Guillain-Barré syndrome.
Yes, Codequina will be in favor more.
So the incidence of GBS in Middle East, I think it's similar to other globally, 1 in 2 in 100,000.
But I think the Amman form is more common in.
Yeah.
We see Amman
Maybe.
form more than the
Especially
classic
from the
EIDD1.
Indian subcontinent. Well, what is the initial finding of NCS and EMG and GBS? I think we answered this question.
In the earliest finding, right, if it's not normal, is prolonged F waves, right?
Sometimes
Yes,
the
the
earliest
studies
finding I
of
found
waves,
is
H reflexes, even other parameter, even the SNAP of CMAP can be affected, but with less frequency than H and F reflexes. So even it's early, you can find some abnormality.
Do you guys treat? Do you guys wait till the patient can't walk independently for 10 meters before you treat them? Do you use that guideline?
No, for me, once I diagnose GBS and patient complaining of weakness, I start the treatment.
Yeah. How about you, Dr. Abu Bakr?
If we keep doing this, the patient will move to you and you will give the IVIG and I will be the bad guy. So I end up giving them.
Yeah.
So
I mean, if it makes, I mean, the idea of giving it, even if they still able to walk, is that they may recover faster. Why wouldn't you do that? Because the evidence isn't there, I guess. Okay, I understand.
So if you go by evidence, yes, but I mean, practically we give it to them because usually people like to recover faster. Even if you tell them after 6 months the outcome is same, they will still need to give it. How many sets of plasmapheresis should you give?
Usually the standard is five plasma exchanges, and if it's very severe or you're not seeing much, we can give up to 7. That's what I usually do.
Okay. I asked one of the experts, actually, Dr. Bashar Qatarji. He says you give it as much as possible so long the patient is still having weakness. The highest number he gave was 12 sessions, which is probably too much in my opinion.
How much is he exchanging every time that he does a session? That's the question.
I think the standard dose was similar from what I remember. Okay, I think we should conclude the talk. Thank you very much, Dr. Aisha and Dr. Deepkaid. And we see you for sure in the next future for another neuromuscular series. Thanks very much.
Thank
you all. Thank all the attendees. Thank you.
Thanks.
So we reached almost 730 at the highest. So that's a big number. Thank you all for attending this session. Bye.
Goodbye.
Good night.
Thank you, Dr. Abu Bakr. Thank you, Dr. Aisha. Dr. Dick.
Thank you, Eric. Bye-bye.
Thank you.